Every trauma surgeon in the world learns from a textbook one man wrote. He'll be 79 this year. He stopped operating years ago. He doesn't need to. His signature on a protocol, 4 pages, single-spaced, becomes law in every emergency room from Los Angeles to Lagos within 18 months. Most people at the top of this world never held a scalpel in the last 5 years of their career. They held something else. You don't know what yet. This is every level of a trauma surgeon, from medical student to writing the textbook. Level 1. The Sub-Intern. You are 24 years old, 4th year of medical school. The sub-internship is the audition. 4 weeks on the trauma service, working the intern schedule before you've earned the title. You carry no patients. Your pager is someone else's. You are there to learn the choreography. 2:26 a.m. Code 1 activation. Pedestrian versus auto. 8 minutes out. 12 people move into a room the size of a living room. Nurses cut clothes. Respiratory therapy preps the vent. The senior resident runs primary survey. You scrub in after everyone else is already gloved. The attending opens the abdomen from xiphoid to pubis. The smell hits first. Blood and bowel prep. Grade 4 liver laceration. He calls for lap pads, not into the laceration, around it. 4 pads on top of the organ, 2 more on the sides, by manual compression. You are holding retractors, arms inside an abdomen that belongs to someone your age, and your job is not to let your hands shake for 15 minutes. The attending doesn't say your name once. The operation ends at 4:17 a.m. The patient lives. You walk out, scrub top soaked through, and you learn the first rule of the trauma bay. Nobody debriefs you. Not for this patient. Not for the 15-year-old gunshot victim on Tuesday. Not for any of them. You sleep 4 hours. You return at 6. Total compensation, $0. You are carrying $220,000 in medical school debt. The interest is accruing tonight. You don't know yet. You'll hold retractors 300 more times before anyone hands you a scalpel. The rotation ends, the intern stays. Level 2, the intern. You match. You move cities, your license prints, your first overnight shift as an intern starts at 6 p.m. on July 1st. Total compensation, $74,000. Your debt is now $230,000. $22.35. Your pager, code 1, pedestrian versus auto, pressure 60 over palpation, 8 minutes out. This time you are in the bay, not watching. In the bay. The senior resident runs primary survey. You do what interns do. You start a second large bore IV, you draw trauma labs, you try to get a Foley in while 12 other people move around you. The fast goes up, fluid in Morrison's pouch. The senior calls massive transfusion protocol. 1 phone call to blood bank, 15 minutes. A cooler arrives with 6 units of O-negative packed red cells, 6 units of AB plasma, and 1 pack of platelets, 1:1:1 ratio. Your job for the next 90 minutes is to squeeze bags, hang products, document every unit, and draw labs after every 6th. You do this 4 more times that week. You find out by accident, from the post-call attending in the call room, not from a teacher, that sleep deprivation at your level impairs cognition the same way a blood alcohol of 0.05 does. You are legally required to operate on people in this state. Nobody writes this down. Your girlfriend moved with you. You promised her the first year would be the worst. She wasn't wrong to believe you. You missed the anniversary dinner, then the birthday. Then you stop counting what you miss. 13% of general surgery interns do not return for PGY2. You will not be one of them. But by March, you will understand exactly why they left. You make it through. The pager follows you to PGY2. Level 3, the senior resident. You are 28, 3rd year of residency. Total compensation, $87,000. By now, you are the one running the fast. By next year, you will be the one calling trauma activation criteria. The senior resident is the person who runs the bay when the attending hasn't walked in yet. Your first damage control laparotomy as the assisting hand. The patient is 21 years old, gunshot to the abdomen, pressure 40 over nothing. You and the attending scrub in, the incision goes from xiphoid to pubis in 1 cut. Blood pours. You pack all four quadrants, 4 to 6 lap pads placed around organs, not into lacerations. The bleeding slows. You hold compression while anesthesia catches up. This is the lethal triad: hypothermia, coagulopathy, acidosis. The operation itself becomes the threat if it goes too long. The attending watches the patient's temperature on the warmer display. The decision to stop, to close temporarily, transfer to the ICU, resuscitate the physiology, return in 24 hours for definitive repair, is called the damage control decision. The attending makes it. You watch exactly how. What no one tells you as a third year is that your generation will graduate with 31 trauma cases logged. The residents who trained you logged 42. Splenectomies per graduating resident have dropped from 5 to 2. Liver operations from 4 to 2. You know the decision trees. Your hands know fewer operations than the hands of the person who taught you decision trees. PTSD screens catch 22% of surgical residents at this stage. Another 35% sit in the at-risk range. The American College of Surgeons published a bulletin in 2022 titled, "Exactly. We suffer in silence." You walk out. You wash your hands. You see the next patient. That is the culture. Nobody teaches you another one. One more year, then it's your bay. Level 4, the chief, then the fellow. You are 31. Your title is chief resident. Total compensation, $98,000. 2 years from now, you will be 33 in fellowship, still on trainee pay. As chief, you are the last call before the attending. The R3 is in the middle of a laparotomy and cannot leave the room. A pedestrian strike with a pressure of 60 is 5 minutes out. You take the call. You walk to the bay. You run the fast yourself. You call for blood before the patient is on the table, and then you make the decision that defines chief year. You call the attending, or you start without them. The attending's house is 20 minutes away. Your program gives you in-house operative privileges for immediately life-threatening emergencies. The question of when to call, when to start, and when to wait is your entire education this year. Then you graduate residency. You move cities again. Wherever the fellowship is, not where your partner lives. You do 2 more years: surgical critical care year 1, acute care surgery year 2. You open someone's chest in the emergency room. The patient arrives in extremis, penetrating chest trauma, no output, no pulse. Left anterolateral thoracotomy. You cut through skin, fat, intercostal muscle. You crack the ribs apart with a Finocchietto retractor. You reach inside. You massage a human heart with your bare hand. A resident you have never met clamps the aorta above the diaphragm. 10% survival for penetrating trauma. Under 2% for blunt. You do it because the alternative is certain death, and you are now fast enough to give someone a chance who had none. You are 33 years old. You owe $200,000, a paper published in 2025 in a surgery journal most lay people will never read, reports the one number your program will never show you. The financial return on the year you are living now, trauma fellowship versus simply staying in elective general surgery, is negative. You will never make back the year you spent here. You already knew that. You did it anyway. You sign your first attending contract. Level 5, the attending. You are 34, first attending contract, academic level 1, trauma center. Total compensation, $340,000. Base plus call pay plus productivity. You could have made $450,000 in private practice. You did not choose the money. Your workload by the national benchmark is 26 service weeks a year and 4 to 5 in-house call shifts a month. A common cycle is 7 days of trauma days, 7 nights of trauma nights, 7 days running the surgical ICU, 7 days off. You are never off. You are either on service or about to be. And then the moment happens. A patient arrives hypotensive, fast positive, not responding to 2 units. You walk into the OR. The abdomen is open on the table. You are aware that you have stood in this room before. Someone else was making the call. This time, the call is yours. Stop. Pack. Close temporarily. Transfer to the ICU. Return in 24 hours. There is no one above you to call. There is another attending somewhere in the city who is asleep. You are not going to wake him. You make the decision. You close with a negative pressure dressing. You write the note. You speak to the family. You walk to the call room. The first time you do this is the moment you become a trauma surgeon. You do not mark the date. Nobody does. Half of all trauma surgeons in the United States are, by the Maslach inventory, clinically burned out. That is the highest rate of any surgical subspecialty. 16.3% meet screening criteria for post-traumatic stress disorder, the range documented in 9/11 first responders. What breaks you is not the patients you lose to your errors. It is the patients you lose despite a technically perfect operation. The 20-year-old with a grade 5 liver injury who dies in the ICU 72 hours later because the cells themselves gave up. The word for that is moral injury. It is not the same as burnout. It is what happens when you do everything right and the outcome betrays you. You walk out. You wash your hands. You see the next patient. You were trained for this. You get good. Then the job changes again. Level 6, the Trauma Medical Director. You are 47, total compensation, $520,000, a base plus an administrative supplement. 2 surgeons under you earn more in a good productivity year. You don't mind. Your title is Trauma Medical Director. The service under you runs 1,200 activations a year. The American College of Surgeons minimum for a Level 1 center. Your service is the hospital's trauma program. Your name is on the letter that goes to the verification committee every 3 years. 45 days before the visit, you submit a questionnaire the size of a small book. Then 2 peer reviewers, senior trauma surgeons from other verified centers, arrive and walk every protocol, every case log, every mortality review, every transfer agreement you have signed in 36 months. If they find you non-compliant in any standard, you enter a corrective action process that could end with the loss of your Level 1 designation, which would end your residency program, which would end your research funding, which would cost the hospital tens of millions of dollars. You run the Morbidity and Mortality Conference. Every death gets classified: preventable, potentially preventable, non-preventable. Every preventable death has a corrective action plan with a name and a deadline. Sometimes the name is yours. And then the phone rings. October 1st, 2017. Route 91 Harvest Festival in Las Vegas. The pages start at 2200, mass casualty shooting on the Strip. Within 30 minutes, ambulances and personal cars are arriving faster than triage can handle. 212 patients, 28 damage control laparotomies in the first 6 hours, 67 surgeries in the first 24. The team runs out of chest tube trays and improvises. Dr. David McIntyre took the call at Sunrise Hospital that night. He wasn't famous the next morning. He was on the schedule. Your hospital is a Level 1 trauma center. 85% of Level 1 centers in the United States sit inside safety net hospitals. County-run Level 1 trauma centers in California operate at a mean margin of negative 16.5%. You run one of the most prestigious services in American medicine. The service loses money every year you work harder. The hospital carries it as a civic obligation. You know this. You signed up anyway. A handful keep going past this. Most stop here. Level 7, the apex. There are in this country perhaps 300 people at the top of trauma surgery. You would not recognize any of them on the street. There are 3 paths to stand among them. The first is the national regulator. In March of 2026, Dr. Kristen Staudenmeier of Stanford became the 22nd chair of the American College of Surgeons Committee on Trauma, the first person to hold the role with triple board certification, surgery, critical care, and clinical informatics. What her committee writes into the Orange Book is the legal standard of care for every verified trauma center in every state. She will have operated less in the next 10 years than you did in your 6th. The second is the military apex. At Fort Sam Houston, Colonel Jennifer Gurney runs the Joint Trauma System. Her committee writes the clinical practice guidelines that determine how every deployed American surgeon operates in every future war. Colonel John Holcomb founded the system in 2003 under Central Command. Frank Butler, a Navy SEAL physician, wrote the tourniquet doctrine that dropped American battlefield limb hemorrhage deaths from 26 a year to 9. He received the Presidential Citizens Medal on January 2, 2025. Most trauma surgeons have never heard his name. The third is the canonical voice. Dr. Kenneth Maddox ran Ben Taub Hospital's trauma service in Houston for 3 decades. He co-wrote a textbook, not a textbook, the textbook, 9th edition, 3,000 pages. Every trauma surgeon training in every country on earth has read a chapter from it. The surgical suite at Ben Taub is named after him. He is 79 years old this year. He still answers email. You have not operated much in the last 5 years. What you have is influence. Your signature on a 4-page protocol becomes standard practice across 50 states within 18 months. After the next mass shooting, you will fly to Washington. You will testify before Congress. You will come home. Nothing about next Tuesday's schedule will change. You do not tell residents this. Nobody did when you were their age. One day the phone stops ringing. 2:26 a.m. Somewhere, right now, a Code 1 activation hits a pager. A 24-year-old in a long white coat stands outside the trauma bay. She is a 4th-year medical student. She has been on the rotation for 6 days. She has not slept. The doors slide open. A gurney comes through. Someone calls for lap pads. Someone calls for blood. She looks down at her hands. She is holding retractors she has not used before. Her arms will not shake. She already knows that much. The rest, the 15 years, the $200,000, the pediatric gunshot victim on Tuesday, the first chest she opens in an emergency room, the first call that is hers with no one above her, the first preventable death she signs her name to, the textbook she will one day read from, the phone that will one day ring after the mass casualty. None of that has happened yet. The attending inside the bay calls for suction. She walks in.